Decreased serum potassium concentration can result from inadequate potassium intake, increased potassium excretion, or a shift of potassium from the extracellular to the intracellular space. Increased excretion is the most common mechanism. Poor intake, or an intracellular shift, by itself is a distinctly uncommon cause, but several causes often are present simultaneously. Spurious hypokalemia occurs when blood with high, white blood cell count is allowed to stand at room temperature. The mechanism is, white cells may simply take up the potassium in the blood specimen. Redistribution hypokalemia is caused by the entry of potassium into cells. Only a small amount of total body potassium is located in the extracellular compartment. Consequently, a small shift of potassium from the extracellular space to the intracellular space can cause a large change in plasma potassium concentration. One very rough guide to the magnitude of the shift is that the serum potassium concentration falls by about 0.3 milliequivalent per liter for each 0.1 increase in pH. Factor replacement therapy for severe megaloblastic anemias results in the rapid assimilation of potassium into red blood cells as they are produced. This fall typically occurs approximately 2 days after beginning therapy for the anemia. In most cases of extrarenal potassium loss, renal potassium conservation is present. Severe secretory diarrhea results in loss of potassium with bicarbonate, resulting in hypokalemia and metabolic acidosis. Villus adenoma of the rectosigmoid colon may present with hypokalemia, often associated with metabolic acidosis. Chronic laxative abuse can result in severe potassium depletion and metabolic alkalosis. Sweat has a potassium concentration of roughly 9 milliequivalent per liter. Athletic training or hard work in the hot sun may produce up to 12 liter per day of sweat and significant potassium deficits. Many of the disorders causing renal potassium loss are also associated with acid-base disorders. Therefore, it is customary to classify the numerous causes of renal potassium loss according to whether they typically occur together with metabolic acidosis, metabolic alkalosis, or no specific acid-base disorder. Distal renal tubular acidosis is due to inability of the renal tubule to eliminate hydrogen ion adequately. The syndrome of metabolic acidosis, caused by impaired proximal tubular bicarbonate reabsorption, is called proximal renal tubular acidosis. In DKA, the metabolic acidosis is due to the generation of keto acids, which are produced by the incomplete oxidation of fatty acids. Metabolic alkalosis is almost always associated with hypokalemia because virtually all of the conditions that cause metabolic alkalosis also led to potassium depletion. In many types of metabolic alkalosis, the excess bicarbonate acts as a poorly reabsorbable anion and carries more sodium to the collecting tubule, leading to increased sodium-potassium exchange and urinary potassium loss. This can be especially important in states of ECF volume depletion that are associated with higher levels of aldosterone. Recovery from acute renal failure, post-obstructive diuresis, and osmotic diuresis can all lead to renal potassium loss and significant potassium depletion. The most important mechanism in these conditions is increased delivery of sodium to the collecting tubule, resulting in increased potassium secretion. A very important and often overlooked cause of renal potassium loss is magnesium depletion. Magnesium depletion induces renal potassium loss by complex mechanisms. It is very difficult to correct the potassium deficiency until the coexisting magnesium deficit is corrected. The urinary potassium loss will continue despite large replacement doses of potassium. Penicillins can cause renal potassium loss by acting as poorly reabsorbable anions, which thereby increase distal sodium delivery and sodium-potassium exchange. Gentamicin and cisplatin have direct tubular toxic effects that induce potassium loss. The symptoms of hypokalemia are nonspecific and predominantly are related to muscular or cardiac function. Weakness and fatigue are the most common complaints. The muscular weakness that occurs with hypokalemia can manifest in protean ways. Rarely, muscle weakness progresses to frank paralysis. With severe hypokalemia, muscle cramps and pain can occur with rhabdomyolysis. Occasionally, a patient may complain of worsening diabetes control or polyuria due to nephrogenic diabetes insipidus. Patients also may complain of palpitations. Patients are often asymptomatic, particularly with mild hypokalemia. Symptoms that are present are often from the underlying cause of the hypokalemia, rather than the hypokalemia itself. When the diagnosis of hypokalemia is discovered, investigate potential pathophysiologic mechanisms. Hypokalemia is defined as a condition in which the serum potassium level is less than 3.5 milliequivalent per liter. A urine potassium assay establishes the pathophysiologic mechanism of hypokalemia. A spot urine potassium measurement is the easiest and most commonly obtained test. Low urine potassium suggests gastrointestinal loss, poor intake, or a shift of extracellular potassium into intracellular space. High urine potassium suggests renal loss. Perform an ECG to determine whether the hypokalemia is affecting cardiac function or to detect digoxin toxicity. The ECG may show atrial or ventricular arrhythmias, decreased amplitude of the P wave, or appearance of a U wave. CT scan of adrenal glands can be done if there is evidence of mineralocorticoid excess. In patients with mild hypokalemia, not caused by GI losses, dietary supplementation may be sufficient. IV potassium should be given for patients with severe hypokalemia or having cardiac manifestations. Administration through central venous lines is preferred. Patients receiving IV therapy should have cardiac monitoring and serum potassium level checked frequently. Serum magnesium should be checked and replaced, if needed. Hypokalemia can occur during the course of treatment. Concomitant administration of potassium-sparing diuretics magnifies risk of hypokalemia.